Hello, everyone. Well, mid-bite. Happy Friday. Nice to see you all. Thank you all for joining us. For those of you who are feeling especially kind and nice, please turn your videos on, except Julia, who's on her bike right now. I hope your video stays off until... Oh my gosh, Jerome is here. What's up, Jerome? How are you?
How are you? You caught me mid-bite as well.
Oh, nice. Look at that. I find my targets well. What are you up to today?
I'm in clinic, so I'm on my lunch breaks. I just stopped by the library to see if I can
Amazing.
find a nice setup to kind of do some
Amazing.
learning today.
Awesome. Well, super excited to see you. Thank you for joining. I see Harnoor is here too. Harnoor, hi, nice to meet you. Thank you for turning your video on.
Hi, nice to meet you.
Tell us where you are.
I'm from India, Punjab,
Yeah, where in Punjab are you?
Mohali, Chandigarh.
Wow, I bet Anmol knows exactly where that is. Do you, Anmol?
Yes, it is the main capital of I know it's very close to my home.
Oh,
About
wonderful.
yeah.
That's amazing. That's so cool that you guys are so physically close despite the many distances that separate us. Thank you so much for joining us, Harnoor. It's very nice to meet you.
That's nice.
Naureen is here too. Hi, Naureen. Also originally from India.
Yeah, hi everyone.
What are you up to today?
Just chilling, did my day off. So
That's a lie. We get to now. Naureen and I are meeting in a few hours. I'm very excited to see you. I am really looking forward to it. I knew the answer to the question even before I asked it. So
excited to be here.
amazing. Simi, you're also here. Hello. I've seen you a couple of times before. Thank you for turning your video on.
Hello, really learning a lot from CP Solvers. I've just recently joined, but I'm really enjoying it and loving it.
Where are you based?
I'm from Pakistan.
Where in Pakistan?
Lahore.
Oh, no way. You know, I grew up in Lahore. I spent 12 years in Lahore.
Wow, that's amazing.
Yeah, where in Lahore are you from?
Just the Lahore city. Do you want like specific?
I grew up in Johor Town. Are you anywhere close to Johor Town?
No, I'm in Beria Town, like it's close.
Oh yeah. Oh, I used to go to Barra Town all the time. My best friend actually still lives there.
Wow, that's
yeah.
amazing.
Yeah, for those of you who care to know about Lahore specifics, which is probably zero, Barra Town is probably the newest sort of like area in Lahore that did not exist when I first went to Lahore and expanded into that area, which is so cool. So really nice to meet you. It brings back a lot of incredible memories.
Yes, pleased to be here today and looking forward to the discussion. It's always amazing and superb, and I'm learning a lot.
Thank you so much. I really appreciate it. Erin, hello. You have your video on too. What's up?
Hi, I have aphasia, but I am still trying.
Oh, that's so awesome for you to join.
I like it though. Well played. How are you doing?
Well, thank you for hanging out. I also love your camera angle. It's really
yes. It's a puzzle. It's a puzzle.
Oh, nice. Enjoy. Have a great puzzle, and hopefully we'll have another clinical puzzle for you at the same time.
Yes.
Prof Rez is almost here. He had some urgent clinical things come up, but I will make it I will not make it as hard for him to miss out by getting to hang out with all our wonderful guests here and start to introduce the people who are helping make this happen. Beginning first with our savior, Ibrahim. Ibrahim is one of the kindest souls I know, who was minding his own business until 5 minutes ago, where we desperately needed somebody to scribe, and of course he stepped up to the plate. Ibrahim, I want to hand the mic to you just to say hi and maybe update people a little bit on what's going on in your life.
Hello everyone. My name is Ibrahim and I'm a final year medical student. I am from Sudan, but I'm based in Saudi Arabia, about to graduate. So looking forward to it and looking forward to today's case.
Amazing. It's so crazy to see the graduation be so close to the current time. I'm very excited for you. In my mind, you graduated medical school a long time ago, my friend. Long time.
Thanks, Robbie. Thanks.
Absolutely. Doing teaching points to Zakaria. Zakaria, I'll pass the mic to you to say hi.
Hi everyone, I'm Zakaria from South Africa. Yeah, I'm quite post-call today, bit sleepy, but I couldn't stay awake.
Quite post-call. I love the description. Yeah, I think everybody can resonate with that. I appreciate you jumping into teaching points despite having some neuronal fatigue, I'm sure. All right, last but not least, we've been waiting for this moment for a long, long time. Anmol burst on the scene in CP Solvers as a case presenter almost a year ago, not quite. And then she teased us yesterday by changing her case presentation date to today, through no fault of her own, but allowing David to present his incredible case yesterday. So Anmol, do you want to give us an update on how your life is going and what's new?
Thank you, Dr. Rabih, for the amazing introduction. I was almost certain that your words will make me forget what I have to speak, but I will still say, so good morning, good afternoon, and good evening to everyone present. I actually presented an RLR case last year, around this time last year, and I joined the academy sooner after that. And that's the biggest blessing I got last year, which has continued till this year. And recently, I've also started doing a job in a cardiac emergency unit. And so I'm enjoying and learning every day from those cases and every day from CP Solvers. So couldn't have asked for more. Thank you for everything.
Oh my gosh, your spiel was so good. Anmol, but did you notice what happened? The moment you said blessing, Pop Rez's video just popped up right in the middle of my screen. It was unbelievable. Hello, blessing, Prof. Rez. Nice to see you.
I need to hear your voice every day, man. This is like just calm, soothing. How are you?
Good morning. Prof. Rez, we have Ibrahim rescuing us from an empty scribing slot today. We have Zakaria doing teaching points. And we have Anmol, who has a doozy of a case prepared for you. So if you're ready to inhale the first aliquot, we can rock and roll.
I am ready to inhale, and just Robbie, at 9:30, I have that 5-minute meeting, and then I'll be back.
Should we do a breakout room at 9:30 then?
I would love that.
All right, that sounds great.
Thank you so much. Sorry for being late.
No problem at all. All righty, Anmol. We're ready whenever you are.
Okay, so let's start the case. I've basically divided it into 5 to 6 aliquots, with the last aliquot revealing the diagnosis. The first aliquot will mainly be about the chief complaint, which is fever for 15 days. The chief complaint is similar to Dr. David's case yesterday, so it will be interesting to go through both of the cases. And just a little bit more is, it's a 40-year-old male who came to the emergency department with the complaint of fever for 2 weeks, accompanied by generalized weakness and reduced oral intake. I'll leave it there.
Wow, what a start, Amol. Nice to see you. As always, very excited to co-discuss your case. You know, it's interesting. Probably one of the first questions I would ask him, and maybe you'll provide this information, is like, why now? You know, why is he presenting now? What happened over the last 2 weeks? I think here we've talked so much about fever and what the causes of fever are. I would focus on the duration and his age. And the more the fever persists and the further away you get from acute onset, you just have to now prioritize either atypical infections or malignant and autoimmune processes, or a medication-related fever. I think that's the approach to take here. And on the HPI, we're going to be seeking any clue as to what might be driving the inflammation. But generalized weakness is not a clue. Reduced oral intake could be a clue if he says it's reduced because he's having dysphagia or odynophagia. I don't even want to yet start talking about that because I think so far we just have a glimpse of the problem rather than the full problem to make significant progress beyond saying we're concerned for subacute inflammation in a young person with no known past medical history. Back to you, Amol.
Yeah, perfect start to the case. And to answer the question why he presented now. So basically, he had been experiencing shortness of breath, even at rest, some hours before the presentation. And the fever had been low grade, continuous, documented around 100 degrees Fahrenheit or 37.7 degrees Celsius, the highest being 101 degrees Fahrenheit. And there were no localizing symptoms, no pain in the abdomen, no loose stools, no burning micturition, no rash, no cough, and no night sweats. The patient had recently traveled to another state within India, about 1,500 kilometers away, and reported mosquito bites in his travel and stay. His fever subsided with paracetamol only to rise again. So he got his blood work done from an outside pharmacy, which mainly showed decreased platelets. So therefore, he presented in the emergency department for further evaluation and treatment. Reportedly, he was apparently normal before the trip began. About the past medical history, there is no known past medical history, and the patient is not on any medications. Family history is significant for mother having esophageal cancer, which is now treated, and we could not access the full records. There are no known allergies. And about the social history, as I said, history of recent travel present in North India, where the patient complained of mosquito bites. The patient basically lives in a village, a rural area in India, and drinks half a bottle of alcohol daily, but does not smoke. There is no known animal exposure, and he is a farmer by profession. I'll stop here.
Oh, absolutely amazing, Anmol. I think you've given us a lot of exposure-based clues to analyze this case, and I'd love for Prof. Rez. I'll keep an eye to see, make sure he's free, but I'll pass the mic to him to discuss sort of the unique features of the patient's circumstances, where he is in the world. But I think if you really take the opportunity to enjoy the fact that David and Anmol are presenting related cases, and I happen to be there at David's case yesterday, to really talk about what we're doing here, we're taking a pathway of fever of unknown inflammation. But the reason we haven't made that diagnosis yet is we haven't met criteria for that. But what are the criteria? The first is the patient on history has to not know where the inflammation is coming from. So the journey of FUO begins with the patient saying, I have a fever and I'm not sure where it is. And that's essentially what he said. And what happens next? What happens next is you examine the patient and try to see if you find something that they did not localize. Be it on their chest exam, be it with meningismus, be it with a rash they didn't notice. So fever unknown by history, fever unknown by exam, fever unknown by history, exam, and the microbiology or laboratory, fever unknown by history, exam, labs, and radiology is then termed fever of unknown origin. So right now we enter the space of fever of unknown origin by history alone, and we are waiting to see if that will remain true on exam. But early on, we are given a laboratory clue that the labs will be of enormous value and that the fever will no longer remain of unknown origin given the thrombocytopenia. And so now we're saying this is a fever which has the localizing clue of thrombocytopenia. And so I think Prof. Rez was chatting with somebody else. So Prof. Rez, I was just going to chat about the thrombocytopenia and leave the very rich exposure history just to you to layer on. And so what is the value of thrombocytopenia here? We first have to acknowledge that we're not talking about thrombocytopenia in all comers. We're making two assumptions. The first assumption is that this is isolated thrombocytopenia, which it may not be the case. And the second assumption is that this is an infection driving the fever. Both of those are assumptions that are driven in base rate by the quality of other physicians reporting to you. When they say thrombocytopenia, they usually mean isolated thrombocytopenia. And when somebody is saying acute fever, it usually means infection. So if we have thrombocytopenia from the lens that it's isolated and in fact infection, it has a high predictive value for an infection originating outside the body. There are few endogenous infections that result in thrombocytopenia, And the three ones are severe sepsis, toxic shock syndrome mediated by staph or strep, and an endovascular infection like endocarditis and Lemire syndrome. By virtue of the ability of the patient to survive this process for 2 weeks, these very severe infections are unlikely at play. So when you see thrombocytopenia in the context of an infection, and the infection is not serious from the get-go, the probability of an exogenous organism is through the roof. And so that's why it's very, very important to now say this is no longer fever of unknown origin. This is likely, because of the thrombocytopenia, a fever from an organism that has come from outside the body, and hence the very important scrutiny that Anmol has given us of the patient's environment. And for that, I'll pass the mic to Prof. Rez to see what he makes of it.
Man, you make it, oh my gosh, my mic is not even connected. You make it so easy, Robbie. Let me connect the mic so my voice can be clear for you.
Prof. Rez, poetry is poetry, no matter what mic you're connected to. Keep going.
All right, let me give you poetry, but let me see that I have the capabilities of inserting this USB-C. Okay, here we go. Let's get this on the Yeti. Sound good? All right. I mean, you just set it up so well. Like, and again, I think, Robbie, using that tempo like you did is key here to lower the likelihood of the three causes you mentioned that have an acute tempo, and the patient would have decompensated from a clinical standpoint rather than be able to walk into the hospital. I think, like, I remember my list for thrombocytopenia and a signal or clue to specific organisms. And like the first one that comes to mind, just given the demographics, is malaria. And malaria can involve every organ system, including the lungs, the liver, and it can cause dyspnea through hemolysis. So malaria is something that I would be curious for practitioners in North India if they would just empirically treat, even if, for example, the screen for malaria was initially negative, or if they got this call and they heard the story because they're just that adept to doing that. The other organisms, you know, if Plasmodium falciparum is in, you know, North India, in America it would be Babesia. So that's the American malaria. So, but I don't think that is common there, but tick-borne infections can 100% manifest with fever, thrombocytopenia, and again, hemolysis. But the geographic location is important. The other organisms to consider include leptospirosis, but lepto for 2 weeks, I think it's a little bit too long, but it's something to consider. Typhoid fever, and then again, in the right context, and you just have to look up based on where you're practicing, which one of these organisms are more likely to be the culprit. And then you got to think about dengue, chikungunya, Zika virus. So in summary, when I think of malaria, I think of Babesia, which is a tick-borne infection. I think about typhoid fever. I think about lepto, and I think about dengue, Zika, and chikungunya. I just feel for where this patient is located, the malaria is going to be front and center. And I also already know that the diagnosis of malaria is not straightforward. Like the rapid screen test evaluates for a specific strain, but I already know I'm going to do a thick and thin smear to look for specific parasites. But those are the organisms I can think of. Anything to layer upon that?
Not a progress. Yeah. I think,
and I just have one more comment I'd like to make is that, you know, almost like when someone presents with a little bit of a puncture on their skin, we think about some kind of spider bite. They're like, oh, I must have been bit by a spider. I don't really, I mean, the presence of mosquito bites is an important clue here as to the vector and like the transmission of these possible organisms. However, it could be totally unrelated. It could be. Like, I mean, we're right now, though, we have to lead with that hypothesis. So I think maybe a good exercise for the breakout session, since we're actually, we still have 5 minutes. So let's get another aliquot. Maybe we can pause after the next aliquot.
Thank you for the amazing discussion. Moving to the physical exam. Blood pressure was 100/70. Heart rate was 100. Respiratory rate was 22. And the patient was afebrile at the time of presentation. Talking about the general physical examination, the patient was conscious and oriented to time, place, and person. HEENT, pupils were normal, bilaterally equal in size and reacting. No jugular venous distension, no evidence of icterus with normal conjunctiva. Basically, all the exam was normal. Cardiovascular, pulmonary, abdomen, neuro, extremity, skin, everything was normal as per the reports. And I did not physically examine the patient myself. I will tell about that at the end of the case. About the labs and imaging, we have HP of 14.6, MCV 88.6, TLC was 12,250, with DLC neutrophils 31%, lymphocytes 67%, monocytes 0.8%, eosinophils 0.8%. Platelet count was 28,000. So the TLC also raised to 16,000 during the admission, and the platelet counts, they trended further downwards. Serum electrolytes, sodium was 142, potassium 4.02, chloride 102, so normal electrolytes, calcium 8.6, phosphorus 2.66, RBS was 76, and procalcitonin was at 0.25. Serum uric acid was normal at 4.8. Lipase and amylase were normal as well. BUN was 48. Creatinine was 1.27. Urinalysis at the time of presentation was normal. Total serum bilirubin was normal as well. AST was 57. ALT was 39. Serum total protein was 6.7, with albumin being 3.96. And alkaline phosphatase was 84. Total cholesterol was 162, and triglycerides were raised at 252. I'll stop here.
Maybe I can just summarize the labs for the breakout room, and then we can just go into it. So, Anmol, it sounds like, just to be accurate, sounds like you have a leukocytosis with a lymphocytic predominance, a normal hemoglobin, and a pretty severely low platelet count, with mild acute kidney injury, normal liver enzymes, and high triglycerides. Did I miss anything before we go to the breakout rooms?
Perfect.
Okay. Anything you want to clarify, Prof. Rez, before we open out the space? All right, because you're up to reflect first. Okay, let me open up the breakout rooms. I'll pause the recording, and then just text me, Prof. Rez, when you're back, and I'll let everybody in. All right, Prof. Rez, let's go. What you got?
All right. So this case got pretty interesting. Maybe I'll just share reflexively what I'm thinking, and then would love to hear from you, Rabih, as to what you're thinking. The exam is really important here because subacute endocarditis can absolutely present just like this. And the lack of a murmur lessens that likelihood. And furthermore, like on this exam, going into it, we were thinking about all those infections, and you might get some findings that can make one of those infections more common. Whether it was, whether it was a rash or a conjunctival finding, but we didn't really find that. And I don't want to go in depth what those findings are. I think the real deal here is just the lapse. The thrombocytopenia, I would say, is like moderate to severe. And it's really unique that you have this lymphocytosis. So the question is, what do you do with that lymphocytosis? By the way, I'm like ignoring the triglycerides. I know in the CP solvers world, it's like a clue to HLH, but there's no reason to suspect that yet. As we don't have bicytopenia, we don't have at least splenomegaly detected on exam, and we know that HLH is usually just a consequence of whatever is driving the inflammation. It's not a terminal diagnosis, it's just a proximal. But the lymphocytosis, like if I were to just think about lymphocytosis, and if I were prioritizing the two main buckets, one would be infection, and specifically infectious mononucleosis. I think it's really important to view these lymphocytes via a peripheral smear. And we're already going to do a thick and thin smear because we want to see, are these normal appearing lymphocytes or are they atypical appearing? Because in infectious mononucleosis, it's often that the lymphocytes are atypical, even if their number isn't too elevated. But this is enough for me to send EBV, CMV, and HIV for sure. Those patients often present with fatigue. They can certainly have a fever, and it would prompt me to reevaluate and make sure there aren't any lymph nodes that are palpable in the cervical region. The other bucket that this makes me think of is I'll look at his prior CBC. He's a bit young, but CLL or a leukemia can also present with a lymphocytosis. In addition to CLL, lymphoblasts can present with a lymphocytosis, but I think that's less likely. So for me, the lymphocytes are a clue, but I'm open to the possibility that it's just reactive to whatever the underlying stressor is. So I go down the pathway of saying, hey, is this EBV? Is this CMV? Is this a monoclonal lymphocytosis, which I doubt it? Or is this just reactive? 2 weeks of fever, mosquito exposure, the thrombocytopenia. I'm totally open to the possibility of this still being malaria and that this is just an unusual feature of the malaria. I think it would be a mistake to just anchor on lymphocytosis and say this should guide the entire differential diagnosis. It doesn't narrow it, in my opinion. It just broadens it. So what I would do here, Robbie, and then I'm going to pass the mic to you to hear your thought process, is I would say, okay, Reza, HIV, EBV, CMV, but don't lose sight of malaria, typhoid, lepto, and all the organisms that we, and chikungunya, the dengue, the organisms we mentioned in the first aliquot. I just don't know enough about North India and which one of those viruses. Maybe it's dengue gets prioritized, but I would be looking for all of those possibilities here. Mike, to you, my friend, because I know you're much more elegant than I am in terms of lymphocytosis.
Not at all, Professor. I have absolutely nothing to add to that. My mind is coming at it from the same conclusion. I will come at it from the benefit of, as Anmol said, having a similar setup with David's case of subacute fever yesterday. And I want to draw your attention to one other thing, which is normal, but I think it's abnormally normal, and that's the hemoglobin. So I'll just tell you that David's case, the hemoglobin yesterday, I just looked it up while Prof. Rez was talking, was 10.6.
No.
And we did not ascribe any specific mechanism to that hemoglobin of 10.6 in a patient who had been febrile for a similar amount of time, because we know that anemia of inflammation will ultimately lower your hemoglobin. And I'm fairly intrigued by the fact that this patient's hemoglobin is 15.7, especially since they clearly have had some degree of kidney dysfunction, enough to impair their creatinine and their BUN, but not enough to lower their hemoglobin. So I'm intrigued by that. And I think it's important to pay attention to the hemoglobin in the context of an exogenous organism, because usually we're paying attention in the context of malaria and hemolysis. But I think when a patient has relative hemo concentration, you want to invoke the idea that the patient might have an early manifestation of a hemorrhagic fever. And what's really counterintuitive about all the hemorrhagic fevers is they first cause leak of blood vessels, causing hemoconcentration, followed by overt hemorrhage. And so I think a hemoglobin of 15.7 is totally normal for this man, except that he's been sick for 2 weeks now. And so part of me is wondering, okay, is this a clue that we should look for vascular leak organisms, the champion of which is dengue worldwide? It's unfortunately prevalent in India, and I know that because I had dengue myself only a few miles away from Anmol on the other side of the Indian-Pakistan border. I actually didn't go to the hospital, so I presume I had dengue because it was very painful and debilitating. But as Prof. Rez knows, I get sick every third or fourth week from something, so who knows what it actually was. But I'll come to the same conclusion that Prof. Rez does. The problem with dengue is that it's actually a condition that you cannot treat with any specific medications. You just have to hemodynamically support the patient. So all that I'm doing is like, I know this patient could have dengue, but I think the focus should always be on the exogenous organisms that you can give specific treatment for. And that always begins with malaria and malaria treatment. It then moves over to antibiotics like ceftriaxone, which can treat salmonella and leptospirosis. And most importantly, antibiotics like doxycycline. So I think at this point, I would think, of course, at CP Solvers, we know to test for all these fancy smancy things, but should I give this patient malaria treatment? I think I would probably hold off because the combination of lymphocytosis and a high hemoglobin is unusual enough. It gives me a little bit of license. Should I give this patient ceftriaxone for salmonella and leptospirosis? And I think there's not enough features to empirically go that way. Should I give this patient doxycycline? I think I'd probably be pretty close to giving them doxycycline, honestly, in large part because this could easily be scrub typhus, an infection that is very common in India and can easily cause this pattern. So if I were to give them anything before treatment, it would be a lot of fluids because that would be the management for the possibility of a viral leak syndrome. And I would think about giving them doxy. But ultimately, the key thing here is to not lose sight of the deadly infections that you can treat. So the infection that matters most right now is malaria, even though, as Prof. Rez, its probability has decreased since with the lymphocytosis and the hemoglobin. All right, Anmol, mic to you, my friend.
Thank you for the amazing discussion. And just to re-emphasize on the point, dengue is very common in North India. Currently working in emergency, I'm seeing many.
No, we lost Anmol.
Many cases of dengue shock syndrome complicated with cardiomyopathy. Can you hear me now?
Yeah, we lost you for a second, but it's good now. Thank you.
Okay, so I was just saying that dengue is very common in North India, complicated dengue. And talking about this case, dengue serology was sent, dengue NS1 was sent, IgM was sent, but was negative. Leptospira IgM was negative. Scrub typhus IgM was non-reactive. Plasmodium falciparum and Vivax for malaria were also not detected. And viral markers, HIV, Hep B, Hep C, they were also sent and the patient was non-reactive. Talking about the peripheral blood smear, it was normochromic, normocytic RBC picture with leukocytosis as described. Reduced platelets, which were normal in morphology and no hemoparasite. They later also detected the presence of myelocytes and metamyelocytes in the peripheral blood film. Flu panel for influenza A, B, RSV, influenza A, H1N1, and H3N2, they were not detected. Echo showed EF of 60% with normal LV size, normal systolic and diastolic function. HRCT chest was also done, which showed elevated domes of diaphragm with basal atelectasis. Minimal left pleural effusion and bilateral and splenomegaly was also seen. There was no evidence of consolidation or cavitation. And the last imaging I'm going to give is ultrasound abdomen. Liver was enlarged. Liver span was 20.6 centimeter. Increased echogenicity, reflective of fatty liver grade 3.
I have no vaccines anymore.
And intrahepatic biliary radicals, they were not dilated. CBD not dilated and normal portal vein. Then spleen was also enlarged, 17.5 centimeter. And as I said, minimal left pleural effusion. I'll stop here.
Oh, this got really, really interesting. And I think it got interesting in large part because of the peripheral smear. But I think it's really, really important to keep track of all the data that we got. And I think we got a lot of negative infectious studies with very good but imperfect test characteristics. And I'm just tracking the couple of infections that Prof. Rez mentioned that Anmol has not given us the results for yet, which may not have been tested, including EBV and CMV. But I think that, when you hear that there's monocytes and metamyelocytes on the peripheral smear, you have to pause and be careful and worry, because these are premature myeloid cells. As a general principle, the more premature your cells in the periphery, the more likely the problem lives in the bone marrow. Neutrophils are the most differentiated cell in the myeloid lineage, and so because they're the least immature, they're often not the result of a bone marrow problem. And then you make your way back from neutrophils to bands, to myelocytes, to metamyelocytes, and then to blasts. I had an eye-opening case report that taught me that you can even get blasts from a severe peripheral process. In that case, it was the receipt of GCSF. So there's a spectrum: neutrophilia, peripheral, blasts, marrow. Where do myelocytes and metamyelocytes lie? They certainly lie much more towards an actual problem with the hematological system, a hypothesis that's further reinforced by the fact that the patient has signs of hematological perturbance in the form of the splenomegaly. So I think that smear abnormality is really, really hard to ignore. And you may ask the question, how does the smear reconcile with the lymphocytic pleocytosis? And the reconciliation is because lymphocytes are detected on the automated smear can be erroneous. So the fact that we don't see peripheral smears, the fact that we don't see lymphocytes on the peripheral smear is very, very concerning, that the lymphocytes that were read on the manual were incorrect. Mengyu was the first to teach us this lesson when she presented a case of acute myeloid leukemia that actually initially presented as a fake out lymphocytosis, even fooling an expert hematologist. So it can fool anybody. So I really, really appreciate Anmol teaching us that lesson, that you don't know a patient has lymphocytosis until you've looked. And so we no longer have a lymphocytosis problem, we have a different one, which makes me less eager and keen to get the EBV and CMV, because those were under the problem of God, I think this person is accidentally muting and unmuting. Okay. I think now the question becomes, how much progress do we move towards the bone marrow? And I think we should move there with intensity given these findings. But I think you ask yourself, are there any peripheral causes that are worth knowing of myelocytes and metamyelocytes? And I only know one. I don't know that many that are exogenous organisms. This smear would be very much in keeping with a pyogenic bacterial infection, but the absence of bands and the absence of neutrophilia would be unusual. It's important to know that there's a really cool infection that Sammy presented, hantavirus, which actually causes a premature myelocytes and metamyelocytes, and actually causes a vascular leak syndrome. But that's actually not so common in India. It's very common in the Americas, essentially in Arizona, New Mexico, and other places. So that's not something to think about, but I just wanted to throw out that association. So I think what happened, we no longer have a lymphocytosis. We have myelocytes and metamyelocytes, raising the concern that the problem might be inside the bone marrow. A really, really humbling lesson about the differential diagnosis of lymphocytes on the manual smear. But that's where I'm headed. I'm curious, Prof. Rez, what thoughts are crossing your mind?
Yeah, I think it's so helpful. And Robbie, I'll tell you another really important teaching point here is that we go hunting for exposures, and it can mislead us in terms of where we end up. But I think it's important to hunt for those. But you just don't want to anchor. And if something doesn't match your illness script, then you have to deviate from that initial hypothesis. So if we said mosquito, North India, we all would run towards malaria. But then you made the point that, hey, the hemoglobin is up, the smear is not consistent. Now we got to broaden and be open to the possibility that this has nothing to do with the farming, the mosquitoes, or anything like that, because now we're getting data that's pushing us away from our initial hypotheses. For me, with the liver, the spleen, and the marrow, I think it's going to be either an infiltrative process in the form of granulomas, because we're using tempo, it's subacute, it's not going to be a common typical infection. And just very briefly, those granulomas existing in the form of TB, fungal infections, and even atypical bacterial infections. Or it's a stem cell disorder that has leaked from the marrow and is now infiltrating the liver, the spleen, and is presenting. So I think both hypotheses take us one direction. And it's what you said, my friend, straight to the marrow. And it's so interesting. Usually when we look at a CBC, it's when you have more than one cell count down that we leave the periphery and we go towards the marrow. But in this case, we only so far have one cell line down, but based on those immature cells, we're still going towards the marrow. And so ultimately, I think we need a bone marrow biopsy specifically looking for a monoclonal population of cells to clinch the diagnosis of a leukemia, or looking for some kind of granulomatous process favoring, though not necessarily confirming, an infectious etiology from TB to leishmaniasis to histoplasmosis to Coxiella burnetii. But those, I think that's where I am. I would be curious to you. I feel like it's those two buckets. Mm-hmm. Do you favor one over the other, Rabih?
Yeah, I think, Prof. Rez, I think the core question, as you said, is are these metamyelocytes and myelocytes inherently abnormal? Or is there something else abnormal taking up space, pushing these cells out? And I think it's hard for me to actually make a prioritization, because I think the acuity and the fever support the notion that there is an invasive process of the marrow. But I think if I were to query what diseases do I know that feature thrombocytopenia and those infections, that's the part that gets me. And so I think, I'm not sure. For me, in my head, it's 50-50. Maybe because I'm scared of Anmol's cases that I'm unwilling to hedge a bet. Yeah, I'm not sure. I think there are features of both aspects, honestly. But I think this case will allow me to refine my knowledge. Because how many times have we discussed the case proper as a fever for 2 weeks, metamyelocytes and myelocytes and thrombocytopenia? The thread of these things is not something that I feel like I've seen many, many, many times. And just so you know, Prof. Rez, this is Anmol's simple case. She has a more complicated case for us and RLR in the future. So Anmol, I said enough. What do you have next for us?
Thank you for the kind words, Dr. Rabih. But you are absolutely correct. We definitely, the next test was the bone marrow aspiration and biopsy. Blood cultures were negative, and the bone marrow biopsy peripheral smear, the bone marrow biopsy imprint smears, they showed predominantly normocytic normochromic RBC picture. Leukocytosis noted with the presence of blasts or atypical lymphoid cells constituting 18% of all nucleated cells. Platelets were reduced in number, and the DLC basically was neutrophils 25%, lymphocytes 39%, and blast or atypical lymphoid cells were 28%. So the bone marrow biopsy and imprint smeared, it showed hypercellular marrow exhibiting sheets of blast cells, overall cellularity 90 to 95%. These cells were large in size, having high NC ratio, fine chromatin, inconspicuous nucleoli, all the features of malignancy, and the impression was of acute leukemia in this case. So after that, another test was sent which confirmed the final diagnosis. And I will continue with that given the time. The flow cytometry was done. And the markers which were positive were HLA-DR. Then TDT was positive, which is concerning for lymphoid blast. CD19 was positive. Then CD79A was positive. CD22 was positive, CD10 and CD34 was positive, which are all concerning for B lymphoblast. So the immunophenotypic findings, they were consistent with precursor B lymphoblastic leukemia in this case. And mainly the interesting thing was the patient was totally apparently normal before the travel. So everybody was mainly concerned about dengue in this case. And ultimately the diagnosis was of acute leukemia.
I'm just humbled beyond belief, Anmol. I just want to really, really, in all seriousness, commend you for such an incredible presentation, because you allow us to live authentically in the journey that people who took care of this patient and allowed us to really, really live in the reality of infection, which is exactly what I think I would do in real life. And it's only upon the detection of the peripheral smear where this case radically changes. So I'm very, very grateful for you for that lesson. And I think for all of us learning medicine, I think this case proves to you that you're going to have to be studying and learning forever. Because if you ever were told that you can have a patient with acute leukemia who has a hemoglobin of almost 16, I think you would really, really have to update your illness script for acute leukemia, a disease that we classically associate with deep anemia and deep thrombocytopenia. And look at this. The platelets are almost gone, and yet the hemoglobin is high. So it just goes to show that the concept of illness script flexibility, to be able to say, actually, I'm going to bend my leukemia illness script so much so, basically almost break it by saying that there's a hemoglobin of 16. And that's why you always, always, always be learning. And I'm just so, so, so grateful that I'm learning alongside my older brother, Prof. Rez, and on this journey for 5.5 years together, refining our understanding of these diseases, and increasingly so with the younger generation of people who are teaching us through incredible cases. So thank you. I would not have predicted at all until you gave us that smear. It wasn't even on my mind, acute leukemia. So really, really thank you, Anmol, for an enriching case. I'll pass the mic to Prof. Rez, who is now talking to somebody else, so maybe not. Yeah, maybe we can hear. Oh, it seems like Prof. Rez is free. Yeah, Prof. Rez. No, I'd love your reflections. What are you thinking?
No, I agree completely. I just want to thank Anmol for presenting such a fantastic case. And I could see why this case was so exciting for you, because you probably reflexively were like, this is dengue until proven otherwise. And that was the right approach. That was totally the right approach. But I think once you start getting data that mismatches that illness script, so it just shows you how difficult the process of clinical reasoning is, where at one point we're saying, be flexible in your illness script. At the other point, we're saying, hey, no, if it doesn't match, deviate from it. So knowing when to do that only comes with experience, reflection, and growth. But I think my final words is just that, like, I think malaria and dengue should be number 1 and 2 until proven otherwise. But you just got to leave your space. You got to leave yourself space for the proven otherwise. And I think, Robbie, you did that so well when we started getting that peripheral smear. So it was awesome to see you highlight both the hemoglobin to prioritize dengue, and then to highlight the immature white cells to be like, wait a minute, let's move away and consider a primary bone marrow pro. I thought that was brilliant. But anyways, enough of us talking. I think the main person that needs to speak right now is Zachariah. Unfortunately, I have to leave and staff a case. But Zachariah, I know it's going to be epic. Thank you all. See you guys later.
Bye, Prof. Rez.
Bye, Robbie John.
I have advanced knowledge that Anmol has some things to share. So maybe before Zachariah, you summarize all the learning, you should capture what Anmol has to say about her case. Anmol, take it away, please.
Yeah. So I was not in the team of doctors who cared for this. I basically got the blood reports from one of my relatives, and from there I followed up the case. Sadly, this patient expired and it could not make it. Initially, when the leukemia was not confirmed, platelets were transfused multiple times, but they never improved. And after the diagnosis, much of the chemotherapy sessions were done, and patient developed pancytopenia. Then sepsis occurred with Klebsiella pneumoniae, and after getting diagnosed in April, he was symptomatic in March. diagnosed in April and he expired in July. So that was how I followed up with the case. And what I mainly learned was that ALL mostly arises in children, but in this case it is in an adult. And what are the most to how to diagnose that? I saw that in peripheral blood smear, 40% of the patients, the WBCs are either decreased or normal. That's what I got from Harrison. And in 8% of patients, there are no circulating leukemic blasts in the peripheral blood smear. And the main diagnosis is by bone marrow aspiration and biopsy. And 70% of adult ALLs, they are of B-cell origin. So that's what I mainly thought about that. And around that same time, I was preparing a TP recap presentation on leukemias and lymphomas. So I thought I would share the slides, but I think we're short on time. So I won't, I had two more slides to share. But that was very interesting because I heard about this case in April, and at that time I was like revising those topics. So it just stuck in my head that I need to present this case, as it was very emotional for the family, for everybody, that an apparently normal patient ultimately developing acute leukemia and could not survive. So it was a very, very emotional and very big thing. So I thought it was important to present this case. And probably, I think the symptoms, sometimes they're mostly subjective. So maybe the patient was having some symptoms early on and the patient did not care enough to present. And when the patient deteriorated because of low platelet counts and everything, and then he reported. So that could be a possibility as well. But thank you so much for giving me a chance to reflect upon this case on the VMRs. Thank you.
Yeah, Anmol, really, really appreciate you sharing this case. And I think I imagine almost everybody would love to hear the slides you had prepared because they'll add to our learning. So please, please, please go ahead and share them. And folks, if you have to leave, please feel free to do so. We have not used up the whole hour of the recording time because of the breakout room. So would love to give Anmol the time.
Thank you, but I'll just go through it in just 2 minutes. I just wanted to revise on that. If it plays, I'm not sure if it. Yeah, I just wanted to revise on that we have hematopoietic stem cell which divides into myeloid lineage and lymphoid lineage. So in this case, we were mainly concerned with the lymphoid lineage, and after that, if we consider about lymphoid lineage, we have T cells and B cells, and T cells can be precursor or mature. So in this case, the problem was with the precursor B cells, and the precursor B cell, it causes B acute lymphoblastic leukemia. And if we talk about the whole spectrum of hematopoietic neoplasms divided into myeloid neoplasms, lymphoid neoplasms, and mixed myeloid and lymphoid neoplasms, it fits into this category of BALL. And if we talk about acute leukemia, which is the case in this particular presentation, acute leukemia can be of 3 types, that is B acute lymphoblastic leukemia, T cell acute lymphoblastic leukemia, and mixed phenotype acute leukemia. We have a VMR of mixed phenotype acute leukemia by Dr. Mengu, and I would recommend to check that out. So this was basically how we diagnose and go through acute leukemias, and the differentiation between all the 3 is on the immunologic surface markers, which we do by the flow cytometry. And it's important to do that because the treatment varies according to that, the prognosis varies. So that's what I just wanted to share. Thank you. Thank you very much.
Anmol, I would love to use your amazing teaching to make one quick point that Prof. Rez made early for everybody. If you wouldn't mind going back to the slide that you had, it's a very, very key learning point about the distinction between myeloid and lymphoid. So you had that nice visual of the hematopoietic stem cell. I think it was your first slide. So if you wouldn't mind going to that. So we have to ask ourselves, we found myelocytes and metamyelocytes, an issue on the myeloid side, and yet the patient had a lymphoid leukemia. How is that possible? Remember when Prof. Rez said, and I won't elaborate on his reasons because they're there for you to re-listen, where he said, I worry that there's infiltration of the bone marrow. So what is happening in this case? The myelocytes are normal. So the acute lymphoblastic leukemia crowded out and infiltrated the marrow, forcing the normal myelocytes and metamyelocytes outside. So the actual myeloid lineage is not phenotypically abnormal here. It is normal. It is just telling us that there is a crowded process in the marrow. So in this case, the marrow was infiltrated. It just wasn't infiltrated by granulomas. It was infiltrated by something within it, the lymphoid lineage. So just because you see myelocytes and metamyelocytes does not mean you have an acute myeloid leukemia. You can have an acute lymphoid leukemia forcing normal myelocytes outside of the bone marrow. And I think that, Anmol, your visual helps really, really make that point very, very clearly. I appreciate you doing that. So this, in fact, I would say the final diagnosis is acute lymphoid leukemia resulting in infiltration of the bone marrow, forcing myelocytes out into the peripheral smear. Just to make that concept clear. Alrighty, Zachariah, the mic is yours, my friend.
What a case. Thank you, Anmol. I'll keep it short and sweet and just some of the main things that stuck with me today. The first thing was Rabih, when discussed fever of unknown origin has very, very strict criteria. Firstly, being that there has to be a negative history from the patient not sure where the fevers are coming from, with a negative physical exam, negative labs and microbiology, and lastly, negative radiologic evidence of infection for us to then call it a fever of unknown origin. We then discussed the causes of infectious isolated thrombocytopenia, and Rabih taught us that the exogenous bacteria and exogenous infections are much more likely than endogenous infections. However, there are some exceptions, that including sepsis, toxic shock syndrome, and lastly, endovascular infection. Lastly, I recently learned that endovascular infection can be differentiated from just simple bacteremia, in that bacteremia just caused sort of driving down a highway, and endovascular infection occurs when there's actually a traffic accident and there's a whole highway jam. And because of that, there's sort of source control that needs to occur before you can get rid of the bacteria. We then discussed lymphocytosis, and sort of a simple schema can be divided into the acute versus subacute and chronic causes. Acute being drug-induced, viral causes, and often a fake out, like we saw in this case, where blasts are mistaken on the machine to be lymphocytes. Lastly, we discussed bone marrow disorders are often the most likely cause of peripheral immature cells in the blood, with one notable exception being hantavirus. And a last reflection was to always remain flexible and always remain humble, because there will always be exceptions to what we're taught and things that differ from what we normally thought were true. Thank you very much.
I absolutely love that. The only thing you should always be is humble. The rest will always change upon you. I love that. That was a very, very wise reflection. All right, y'all. We actually have a VMR tomorrow. Unlike the usual Saturdays where it's just the Academy, we have a VMR at 9 a.m. Pacific time, 12 p.m. Eastern, with a special continuation of the IMG and residency initiative. So hope to see you there. Have a great day. Bye.